Please be seated.
Hereby, I open this academic ceremony in which Faysal Benali will defend the academic thesis Brain Resilience and Heparin Flush in Endovascular Thrombectomy for Acute Ischemic Stroke, Challenging Current Literature. Welcome everyone. My name is Harry Schout. I'm Emeritus Professor of Hematology. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much. Dear colleagues, family, friends, members of the opposition team, supervisors, it's a great honor for me to stand here today and to present to you the thesis, the work of my thesis. I'll do my best to explain and present the thesis in an explainable way for the audience. Hopefully, you'll walk away with a few take-home messages, but at least enjoy the dissertation. The title is Brain Resilience and Heparin Flush in Endovascular Thrombectomy for Acute Ischemic Stroke, where we challenge current literature. Before we get into the topic of the thesis is divided into 3 chapters: Brain Reserve, Pre-Stroke Disability, and Heparin Flush. I will give you a brief introduction about stroke. What is a stroke? A stroke is a sudden attack of disability or loss of consciousness that is caused by an interruption in blood flow to the brain. Usually, this is through a clot that blocks the blood vessel. This is called an ischemic stroke. In 80% of the cases, it's an ischemic stroke. It can also be due to a ruptured blood vessel. This is called a hemorrhagic stroke. The top graph resembles a ischemic stroke, where a clot is blocking the blood vessel, and the bottom, where the ruptured blood vessel is causing a hemorrhagic stroke. Most common symptoms of a stroke are facial drop, blurred speech, or arm weakness. It's a major problem in the Netherlands, top cause of death and disability. Around 40,000 new cases in the Netherlands in 2022, that's a bit more than 100 each day. And 1 out of 4 of those cases died. Today there are 2 treatments available: intravenous thrombolysis. This is basically administering a very aggressive blood thinner to dissolve the clot and to open the blood vessel to get, again, blood flow in the brain. And secondly, we have endovascular thrombectomy. The aim of endovascular thrombectomy, or EVT, is to mechanically remove the clot out of the blood vessel and in that way to restore blood flow to the brain. The thesis will focus on this treatment, endovascular thrombectomy. IVT was standard of care since 1995. An endovascular thrombectomy is performed with a so-called stent retriever. A stent retriever, we all know what a stent is. A stent is something that is placed on blood vessels to open the blood vessel, in the heart, in cases of patients who have a heart attack, or in the legs, in so-called etalagebenen. But in the brain it's placed, it's left there for a couple of minutes to give it some time for the clot to integrate in the struts of the stent. As you can see, the dark material is the clot, and then it's retracted, hence the name stent retriever. With this device, endovascular thrombectomy, in addition to what was standard practice back then, IVT, intravenous thrombolysis, became standard of care since the publication of the very first clinical trial, which is published here in the Netherlands, the Mr. Clean trial. After this positive trial, many other trials published the same results around the world: Canada, USA, France, Australia, etc. Endovascular thrombectomy plus IVT, intravenous thrombolysis, was better than IVT alone. So before I'll get to the results of these trials, I'll first have to explain to you the modified ranking scale. The modified ranking scale, or the MRS, is a scale that scores from 0 to 6. If you are on the left side, 0, 1, 2, you are fully independent. You're independent. You have minor symptoms. And the higher your score, the more dependent you are from nursing care, from walking sticks, etc., etc. And the MRS score of 6 is death. if you look at the pooled analysis, this is the pooled analysis of 5 of the 7 trials that I've shown you earlier that proved that endovascular thrombectomy was, in addition to IVT, was better than IVT alone. You'll see that the patients who got only IVT, which is the top graph, and the bottom, so the top graph is patients who only had IVT, and the bottom graph is patients who had IVT and EVT, and you'll see that the light colors, resembling patients who have minor symptoms, are increasing, if you see at the left side of the red line, while the dark colors, patients who have major disabilities, are decreasing. There's also a number needed to treat calculated of 2.6. That means that for every around 3 patients that you treat, 1 additional patient improves. A number needed to treat is a way of telling how effective a new treatment is. The lower the number needed to treat, NNT, the more effective a treatment is. If you would, for example, compare this to cardiologists who put stents in the heart in case of a heart attack, they have to treat 20 patients to prevent 1 patient from dying. So a number needed to treat of 2.6 is very low, so it's a very effective treatment. However, today we know that if you fully open the blood vessel in case of an ischemic stroke, 1 out of 2 of those patients still don't fully recover. In addition, some patients fully recover and other patients don't recover whilst they have the same stroke, especially in the elderly population. And we want to know how this happens and why this happens. And this is forming the backbone and the fundaments of our thesis. Our thesis is, like I said, divided in 3 main chapters: brain reserve, pre-stroke disability, and heparin during endovascular thrombectomy. Heparin is a blood thinner. Let me start with brain reserve, the first topic. I think it's easy to explain the concept, it's a hypothetical concept of brain reserve with this graph. As you see on the bottom left, this is where the stroke occurs. And patients with a high brain reserve will endure the stroke much longer before they get into symptoms, before they decline or decompensate, compared to patients with a low reserve. The brain is simply more capable of counteracting, of compensating for the injury, in this case the stroke, compared to patients who have a low reserve, irrespective of their age. Brain reserve can be quantified. We can look at imaging. We can look at the volume of the brain. So more brain cells is more capacity to compensate for an injury. And we can look at the quality of the brain, and specifically at the quality of the smallest blood vessels in the brain. So if you have less volume, the brain is atrophic. It's called atrophy. And small vessel disease is resembling the disease of the smallest blood vessels in the brain and resembling actually the quality of the brain cells. This is an example of a CT scan. On the left side, you'll see a patient who doesn't have atrophy, and on the right side, the patient has moderate atrophy. This is an example of a CT scan of patients with increasing burdens of small vessel disease. A small vessel disease is actually appreciated on CT by dark areas inside the brain. I'll try to show it to you. Let me see. These areas are resembling the white matter disease. We also know that brain reserve diminishes. The older we get, the less brain reserve we will have. This is called chronological aging, and it's for every patient on the same speed, on the same pace. However, there is also a concept which is called biological brain age. So we have the chronological aging and we have the biological brain aging. And the biological brain aging occurs or goes at a different speed, at different paces for each patient, because it's depending on cardiovascular risk factors such as diabetes, hypertension, smoking, your lifestyle, leisure activities, but also simply genetic predisposition. So we have to make a distinguishment between chronological aging and biological brain aging. And what we actually proven in the first topic is that instead of looking at the chronological aging, the biological brain aging is more important, because the biological brain aging, as quantified on imaging, on CT scans, gives worse stroke symptoms at baseline. So a patient comes in at the hospital and will have worse stroke symptoms and will have poorer recovery after they get treated. In fact, the main reason that the chronological age is affecting your outcome is not due to the chronological age, it's not due to the numbers of years since birth, but is mostly due to a diminished brain reserve as quantified on imaging. So if you know this, then we also know that the chronological age is not modifiable. We cannot modify the numbers of years that you are on this planet, but we can modify the biological brain age by modifying emphasizing stroke prevention campaigns, by controlling risk factors, cardiovascular risk factors, etc. Secondly, as a stroke physician, you will make your treatment decision mostly based on the stroke severity at baseline. So a patient comes in the emergency room and you have to assess the patient, and based on the severity of the stroke, you will decide whether you treat this patient with only IVT or IVT and EVT, or whether you bring this patient with the ambulance to a center that is capable of doing EVT. But a patient who has a lot of brain reserve can have only minor symptoms despite having a full-blown stroke that needs to be treated in a EVT-capable center. So you have to be very careful with your treatment decisions. Thirdly, rehabilitation programs. Now we can inform GPs and physiotherapists about the rehabilitation programs because we see that patients with poor brain reserve will have poor outcome. So you can tailor your rehabilitation program based on your brain age. And lastly, we have to include this information, of course, in future trials to have more reliable and confident results. The second topic this thesis touches upon is the functioning before the patient got the stroke. This is defined as pre-stroke disability. And if you look at the guidelines to treat a patient with endovascular thrombectomy, EVT, you will see that only patients who have minor or no symptoms are eligible. Again, the modified ranking scale, 0 or 1, no symptoms or non-significant disability. However, we also know that in society, population is aging. More and more patients who have some form of disability will get a stroke and will present to the emergency room for treatment. So how do you treat those patients and how do you manage those patients? This is what we did in the second topic of the thesis. We looked at patients who had moderate disability, a pre-stroke MRS of 3. This means they could care for themselves mostly, but the complex cases such as cooking or making a phone call or doing groceries are limited. And again, two groups of patients. The first group is the bottom group. These patients were not successfully treated. And the top group is the patients who were successfully treated. Again, what do you see here? If you look at the red line, and on the left side are patients who are doing well after 90 days. So these groups are increasing, while on the right side of the graph are the dark colors, and these patients are doing not so well after 90 days, and these patients are decreasing. So that means that also the patients with some form of disabilities can still benefit from this highly effective treatment. As I said before, the number needed to treat was 2.6, which was very low. So even those patients can still benefit. And if you would exclusively look at the guidelines, these patients would be excluded, and you would not treat a patient who would otherwise benefit from this treatment. And if you look closely, you will also see that patients are returning to an MRS 0, 1, and 2, while before the stroke they had an MRS of 3. So this would be impossible, of course, because you cannot improve after you get treated. You can maximally go to your status how you were before the stroke. So this also tells us that pre-stroke assessments are not always correct, and we should not focus exclusively on these assessments. So the last topic this thesis looks at is the heparin use during thrombectomy. There is a lot of papers around heparin use during thrombectomy, but there is one crucial way of administering heparin during the procedure that is lacking, that's missing in clinical trials or in the current literature. Let me explain. So in endovascular thrombectomy, when you perform a thrombectomy, you have to introduce catheters and guide wires in blood vessels. You have to think of catheters as small flexible plastic tubes and guide wires such as ropes in these tubes to guide the catheters. Usually this is through a puncture in the groin, but could also be in the wrist or in the neck. And if you introduce these materials in blood vessels, the body will be stimulated to make new clots, usually at the tip of these catheters. And you don't want new clots because this could mean new strokes. And to prevent this, we connect infusion bags. This is a bag with water. It just continuously flushes these catheters to prevent clots forming at the tip. And to maximize this prevention, we put heparin in these bags, which is called heparinized flush. Heparin is a blood thinner and further prevents the formation of clots. However, this does not come without any risks because heparin can cause bleeding in the brain. So we have to make a balanced decision on how much heparin you give to reduce the risk of bleeding and to reduce the formation of new clots. There is no consensus nor guidelines, as I said. So interventionists around the world, they give different doses. And we've seen in the Maastricht University, in the data set we had, that when you increase your dose, as you can see here, from 0 to 25,000 units per liter, the risk of asymptomatic bleeding, SICH, is increasing from around 5% to 10%, so it doubles. So it has a significant effect on the increase of the significant effect of occurrence of symptomatic brain bleedings. Yet, interventionists around the world, as I said, give different doses, as you can see here, ranging from 9,000 to almost 0 units per hour. So this was a summary of the thesis. So we want to challenge established dogmas in the current literature in the stroke world, where we want to challenge firstly the chronological age. Maybe we should more look at the quantified biological brain age on imaging. Secondly, the importance of excluding patients with pre-stroke disabilities. And thirdly, we round caution for heparin use in infusion bags. Thank you.
Thank you for your very clear presentation. I enjoyed it. As a not expert in this field, I also learned something. The opposition will be opened by Professor Bakkes, Professor of Clinical Physics, in particular neuroimaging at this university. He's also the secretary of this committee.
Thank you, Mr. Chairman. Well, the candidate, it's a good point always to start by expressing sincerely many compliments for you for finalizing this very nice scientific thesis. And these congratulations are not solely for you, also for the international promotion team. And lastly, it's also your beloved ones and everyone who supported you in this endeavor that deserves these congratulations. Well, it's not only nice scientific work, but it's also medically very relevant. The thesis delivered by you counts no less than 9 chapters that are already published in internationally well-respected journals. That's quite an effort that you have undertaken for that, and I guess it's not without many hurdles. Well, I'm a medical physicist and not so much in the clinical process, but my expertise is more, and also the interest is mainly on the technology for imaging that you used. You used the term brain resilience, and practically you expressed that by brain atrophy volume reductions, visually scored. Now, you measure this with computed tomography because that's available in the acute setting. Time is brain, but I'm more specialized in another modality that's called MRI. For that, here in our Western society, there is no position in an acute setting in general. Now, in detail, when I look at Chapter 2, you compare the atrophy measures for MRI and CT. And if I have a closer look, you said that the subcortical, there was a difference between cortical and subcortical atrophy measures. Mm-hmm. Is it a big difference? Is it a clinical relevant difference? And why is there a difference between subcortical and cortical volume scores?
Highly esteemed opponent, thank you for your kind words. Thank you for your question. There was indeed a difference. So first of all, exactly as you said, we used CT imaging for the majority of the patients because it's widely available, and we had more than 1,000 patients with available CTs. And what we did in this paper was, so we had our system to provide inter-reader and intra-reader intermodality agreements. And the agreements for global cortical atrophy was exactly a bit more. If you look at the categorical ordinal scales, was a bit better than subcortical atrophy. one of these reasons could be that cortical atrophy is something that is visually assessed, and we also grouped 2 and 3 together. So if you have severe atrophy and 1 separate and 0 separate, and subcortical atrophy was included in this full scale as well, and had all the ratio numbers. So we included all the numbers of the subcortical atrophy together.
Mm-hmm.
If I would,
and for the matter of time, there are many other questions today. A priori, not looking at the results, would you expect a difference between MRI and CT?
yes, we would definitely expect a difference between MRI and CT.
And in favor of what?
I would say in favor of subcortical atrophy, because when you have CT, you can have, for example, you will have less spatial resolution than compared to MRI. You will have, for example, beam hardening artifacts, and I think beam hardening artifacts because it's occurring because of the thick skull. So I think that if you would look at the beam hardening artifacts, that the cortical atrophy would be more challenging to detect on CT compared to MRI instead of subcortical atrophy.
Mm-hmm. Okay, another question is, I mean, you used brain volume, so atrophy as a measure of brain resilience. Can you envision other measures of brain resilience that you could derive from images?
Besides what we use in thesis,
Yeah.
besides atrophy?
Exactly.
Also besides small vessel disease.
That's one. So for instance,
Okay, so yeah, you can use
white matter lesions would be one.
Yeah, you can look at white matter lesions. You can
And others?
So you have your cortical atrophy, your subcortical atrophy. White matter lesions can also be divided in white matter disease, lacunes.
Something about the vasculature?
Well, you can also do very how do you say it? Specific imaging, such as diffusion tensor imaging, and look at how water molecules are diffusing.
Network. And what about vessels itself? I think about collateralization.
Yeah.
If you have collaterals, I mean, that gives you a lot of resilience.
Yes.
Yeah?
Collaterals is already a very important predictor in stroke outcome. So we didn't look specifically at collaterals. We did use it as a confounder, but we didn't look at that specifically.
Thank you. I feel the eyes of the pro-rector, so I give the word back. Thank you very much.
Thanks.
Thank you. The opposition will be continued by Professor van der Schaaf, Professor of Neurovascular Interventional Radiology at the UMC in Utrecht. Thank you for coming to Maastricht.
Thank you. Thank you. So, dear candidate, first of all, my warm congratulations on your fine dissertation. Of course, also my congratulations to the whole promotion team. And I've been reading your dissertation not only as a clinician and as interventional neuroradiologist, but also with a view on the healthcare of tomorrow, where we see a rising number of patients, but also facing a shortage in healthcare staff and resources. My first questions are on chapter 8. And in this chapter, you focus on the effect of heparin flush concentrations on safety and efficacy outcomes in acute stroke treatment, endovascular acute stroke treatment. And you describe that periprocedural heparin could affect functional outcome and also increases risk of intracranial hemorrhage. So I was wondering, what do you think that the main intention is when people are giving heparin during the procedure? And to specify, do you think people are striving for a certain dose or a systemic effect? Or do you think it's just a local effect they're looking for?
Mm-hmm. Thank you, highly esteemed opponent. Thank you for your kind words again, and thank you for your question. I think the use of heparin why people would give heparin is because of two things. Of course, it's a blood thinner, so you will reduce or you prevent the formation of new clots. But secondly, heparin also has an anti-inflammatory effect and can, if you have an ischemic stroke, the microvasculature around the stroke can be blocked because of the cell death of neutrophils, Because when you have an injury in the brain, there occurs inflammation, there are cytokines that are released, and neutrophils will be attracted, and glial cells, and they do their work, and they will also release their cytokines and chemokines, and they will also undergo cell death. And this gives you so-called neutrophil extracellular traps, nets, and these blocks microvasculature around the ischemia, and heparin disentangles those nets.
Yeah. And do you think that heparin needs a certain systemical dose to give this effect, or is just one drip enough to reach that effect?
I think that's a very, very tough question to answer because you don't know. Eventually, if you're thinking about the heparin that is, like in the thesis, in the flush and not the bolus, we don't know how much heparin is really going into the patient. So focusing on your dose would be challenging, but we could perhaps focus on monitoring of the effect of heparin.
And what about if you want to focus on your dose, is just giving a bolus, because then you're sure about your dose? What do you think about considering that instead of heparin flush?
Heparin has a half time of, I think, 1 to 2 hours, and if you give one bolus, it is also given, but then your effect becomes less if you have long procedures. So I think infusion is better during complex procedures.
But you can also add some, I mean, usually a procedure is within 1 hour, and you can add, of course, some of the...
You can add,
yeah.
That's true.
Yeah. Okay.
That's actually, that's true, yeah, you can add.
Yeah. Well, I'm one of the persons giving a bolus. Until now, I might stop with it after after reading your thesis. But actually, my question is, you accounted for bolus administration, I guess, since on page 167 you mentioned that we performed additional analysis, excluding all groups where heparin bolus was administered. And then you refer to supplemental table 2. And I was really curious to see about the results, but I couldn't find it. So maybe you can help me explaining about results of this analysis.
So what we did in supplemental table 2 was exactly, we excluded patients who were administered a bolus.
You excluded them.
Yes, and we excluded patients who were the centers that were very small in numbers, small sample sizes. That was 2,000 and 25,000 units per liter. And then we looked again at the same, we did logistic regressions, and then we got a odds ratio of 0.99, but the same trend, positive odds ratio of 1.2 for symptomatic bleedings.
So the same trend. So it doesn't matter if you give a bolus. There's not an increased risk if you give a bolus of heparin.
It didn't change your it didn't change the effect of heparin flush that much, but and because we wanted to and the exclusion of these small sample centers, of course, didn't change your effect that much, no.
Which is interesting, since I think giving a bolus is already an increased dose compared to the total heparin in the flush systems.
Yeah.
Do I have time for one more question? A small one. Can you give a short advice to me if I'm having an acute stroke patient tonight or tomorrow, how to deal with heparin? Should I give in your opinion, should I give a bolus or a flush or nothing?
Yeah. I think you have to be, I think there is no protocol for each patient. You have to treat each patient differently. So if IVT is already given, if you have not that very low aspects, for example, etc., or patient comes in late, then you have to be very careful. You can give a bolus, but I would then be very careful with the heparin flush.
Okay, thank you. I give the word back to the chair. Thank you.
Thank you. The opposition will be continued by Professor Bogaerts, Professor of Vascular and Interventional Neurosurgery at the Radboud University in Nijmegen. Thank you for coming to Maastricht.
Dear candidate, my compliments with your scientific results, and but also would like to extend my compliments to the promotion team. Before I want to dive into chapter 7, I would like to ask to one of your paranymph to read the proposition number 10, because it struck me, and maybe one of you could read it.
Every minute of untreated large vessel ischemic stroke results in the loss of approximately 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of myelinated fibers in the average patient.
Thank you. So that's an enormous number. How do we know?
That's a very good question.
These animal studies, or how is
Probably
this?
animal studies.
Volumetric.
Probably assumptions in animal studies. I mean, they didn't count the neurons. I would share about that, but it's probably not in human. It's in animal studies and maybe also in vivo studies. To be honest, I don't know how they know this, but.
Okay. Well, good. Well, let's dive into chapter 7. So, MRS of 3. That's what exactly? I mean, you showed already, but if you would describe in your own words, how does it? Because if I read correctly, you checked all the files on those MRS3 patients. So, what's a typical MRS3 patient?
So, according to the definition, an MRS3 patient is a patient who can carry out all-day activities such as showering or going to the bathroom, etc. But the complex things such as making phone calls or cooking or going out for groceries, that they are limited in that. And this is per definition MRS3, and this could be due to a minor stroke that they had in the past, or heart failure, or we've seen many different reasons for that.
But it's a rather broad category.
It's a very broad category.
Yeah, yeah. So, and you checked all the patients, and did you find like discrepancies in the sense that you thought that would be in other than 3? Because the primary investigators, they put the MRS3 and you checked it, and then did you find like you agreed with all those patients, or did you had like concerns that differences?
Yeah. So first of all, it was not always easy to find the reason why there was an MRS3. Sometimes we had to make assumptions ourselves as well. And in that sense, because it's a retrospective study, so we had to go the EPDs in centers all around the Netherlands to look for why did this patient have an MRS3. So,
but more or less you agreed.
More or less I agreed, and with the kanttekening that we made assumptions.
Yeah. So so the number of patients in the registry with MRS3 pre-stroke is very low, right? So it's 5%. So are we missing patients? So are patients not referred in those MRS3 category, or is this the real life? Is this how it is? What do you think?
Well, if you look at epidemiological data, then we know that of all strokes, 20 to 30% are 80 plus elderly. So 5% is, and if you would see this as a proxy of pre-stroke disabilities or moderate pre-stroke disabilities, in that sense, yes, it is much lower than we would anticipate. But remember that these patients are only the patients that were treated with thrombectomy. So it could be that this selection bias would have caused that the pre-stroke disability number was lower compared to the general population that we know.
Yeah. Okay, so I want to dive a little bit into your conclusion, because you have actually 4 points in your conclusion. One, it's like heterogeneous in the sense that the cause of disability. The other thing, it's if you perform, they have like a favorable outcome, those patients, and the vascular therapy might be beneficial. And the fourth thing you conclude, we might need a randomized trial. So if I start with the second thing, so do those patients have favorable outcome? So could you comment on this? I mean, the percentage is not that high. Why do you say it's favorable?
Well, if you look, yeah, that's the first question. What is favorable outcome? If you start out with some form of disabilities, you could argue that favorable outcome is returning back to your status. You cannot be better. And if you look at these numbers, I think it's about 20%.
Yeah, 23, yeah.
And if you look at the numbers that patients who are not successfully treated, I think it's around 10%. So, and if you think about it like that, going from 10% to 20%, if you treat those patients, I think it's worth treating those patients.
It's worth treating. So that brings me to the next point. So if you go for the endovascular activity, if you compare it with, so those who have successful recanalization versus those who have not, you see that there is an absolute risk reduction of 7%. And it's this blue graph you also showed. So, so number to treat, if this is absolute risk reduction, is 14. So it seems to be efficient treatment. But there is an expense. And on the other hand, you increase your category of patients who have an MRS 4 and 5. So it's a little bit the same story with the decompressive craniectomy and ischemic or hemorrhagic stroke. I mean, you have more survivors, but the expense of in severe disability. Could you comment on this?
You indeed see an increase in MRS 4 patients in these groups. Let me think about it. Why this happens, I don't have a clear idea or answer for that. But if you go back to the definition of the modified ranking scale scores, then, and if you would also compare the patients who died, the mortality, which lowered, then it might, I don't know if it's cruel to say this, but it might compensate this in some way.
So the effect is still beneficial overall.
Yeah.
So one quick question, then I'll stop. Last question is, in your supplemental table, you say if you first pass you have a high chance of good outcome versus if you need more times. So can I stop after a first if I don't succeed, or should I finish with thrombectomy?
I don't think you have to think about it like this. We just use this analysis as if you because first pass effect is a great predictor for outcome, and we looked at a first pass effect and non-first pass effect has the same trends.
Thank you very much.
Thank you. The opposition will be continued by Dr. Bernse, diagnostic neuroradiologist at the Rijnstaten Hospital in Arnhem. Thank you for coming to Maastricht.
Dear PC candidate, first of all, congratulations on your excellent work. And of course, also congratulations to the entire research team. So first, I would like to discuss chapter 2 on page 23. And you analyze brain atrophy and compare the reliability of the scores on CT with MRI. And you mentioned that these scores on MRI are primarily used in the context of dementia screening. And from your study, it appears that the scores on the atrophy scores on CT correspond well with the scores on MR. You're a radiologist, so you know that MR is less widely available than CT scans. And so my question is, could you also reverse the results of your study, and could the atrophy scores on CT also be used in the context of diagnostics in dementia?
Okay, highly esteemed opponent, thank you for your question. If I understand your question correctly, the scoring systems we adopted on CT came from MRI, from the world of neurodegenerative diseases. And what we basically did was we looked at how well they were correlated in a new population, stroke population, where you have hypodensities, where you have brain swelling and mass effect, etc. And we tried to mitigate the effects of stroke by looking at, for example, the ICT ratio on the opposite side of the stroke, and then multiplying by 2. And by doing that, we saw that the correlations were equally, or were moderate to perfect for CT and MRI. Can you repeat your question, because I didn't understand.
So could you also use a CT scan instead of an MRI scan for scoring the same scores in the context of dementia screening?
Yes, I think there is literature about of this. For example, the MTA score, hippocampal atrophy. It's validated that you could score this on CT.
And you mentioned earlier the beam hardening, so the hippocampus area. Do you think that it's in an area where beam hardening is sometimes a problem?
Mm-hmm. Of course, CT has this problem. That's true. And MRI is also a better spatial resolution. But there are validation studies that have compared these two modalities with each other, and they found good correlations for these scores on CT.
Okay, thank you. So in the subsequent chapters, you examine white matter disease, atrophy, and functional outcomes. Did you also find any connections between these factors and complication during or after the procedure?
Let me see, it's chapter 3. We didn't, I think we didn't see major differences in complication rate.
Okay, so you didn't see more hemorrhage during or after the procedures in patients with brain atrophy?
No,
okay.
And also there are new studies recently published, also from the Calgary group, that looked at the patient in the ACT trial, where they got tenecteplase and alteplase. And there, if I remember correctly, they also didn't see a significant increase in symptomatic bleeds.
Okay. Do you think that we should routinely report the degree of atrophy in our stroke reports? And if so, where should we place it? Only in the text or also in the conclusion?
This is actually, I think, a bigger point. So how do you implement these results in the current practice and the workflow of a stroke patient? Well, basically, it has to guide your treatment decisions. So if you have, you have to quickly have a glimpse of the brain, on the atrophy of the brain, the small vessels of the brain, but it shouldn't delay your workflow. So if putting it in the conclusion delays your workflow, then I would say no. If it puts it in the report elsewhere, so the main aim is that. So the goal is actually to have a direct image of how the brain looks like, without losing valuable time. And then the second question could be if you would look at it as a human, or should the AI do it? That's also something that that's, I think, a whole other discussion. But to come back to your question, I don't think it matters that much if it's not impeding your workflow to get a quick glimpse of your brain reserve.
Yeah, well, as you mentioned, it could be relevant, for example, for the rehabilitation
yes,
after the...
That's true, so it should be documented somewhere. Yeah.
Okay. One question or no?
Thank you for your participation. The opposition will be continued by Professor Ten Kate, Emeritus Professor of Internal Medicine, in particular clinical thrombosis and hemostasis at this university.
Thank you very much. Dear candidate, congratulations with this accomplishment and also to your supervisory team. It's very clinically relevant and I'm afraid I also have to focus on the anticoagulation part. But first of all, I'd like to ask one of your paranympha to read one of the propositions, number 9, if possible.
The dosage of heparin during endovascular thrombectomy for ischemic stroke warrants greater standardization.
Thank you. For reasons of time, I will be quite brief. I think the key question that I want to ask you is, why would you still use heparin to begin with? Because I don't think it's so much about optimizing doses and timing, because there are many uncertainties, and the question is, why would you administer a harmful drug to these patients in the current situation with the current uncertainties, based on your inventory and the publication of the Mr. Clean Med trial and the subsequent meta-analysis only showing harm, increase in the risk of intracranial hemorrhage, more often imperfect reperfusion due to embolization, distal embolization, and no improvement in functional outcomes. So I think altogether the evidence is not very helpful in showing that we should use heparin. So that's the main question. Why still use heparin?
Highly esteemed opponent, thank you for your kind words and your question. I think together with you, a lot of physicians think the same. If you look at, since the Mr. Clean Med publication, exactly as you said, lots of protocols were changed. I think people were decreasing their amount of heparin. They didn't fully stop giving heparin, but they decreased especially the heparin which is put in the infusion bags. As you can see, the first survey that we did was before the publication of the Mr. Clean Med, and you could see doses ranging to 25,000 units per liter, which is absurdly high. But the second survey, which also included Mr. Clean interventionists, you see that those are lower. And that was the Mr. Clean Med study was in between. So yes, it had really an effect. And exactly like you said, it's causing harm to the patient because it has symptomatic bleeds. However, we didn't see a worse outcome. And I think this also tells you something. If you have a higher chance of bleeding without having worse outcomes, there must be some compensating effect of heparin as well, I think.
Yeah, so you wouldn't dare doing without heparin?
That should be tested in a randomized manner. But as for now, I wouldn't dare it, no.
Okay. Well, final question. You mentioned neutrophils, and that's interesting. There are heparin preparations with very low anticoagulant activity or no anticoagulant activity. Would that be a better option to prevent the harmful effect of netosis in these patients? And would that perhaps be sufficient to protect the patient and not do harm? Would that be a solution?
That would be a great solution if there is a heparin preparate available with lower dose that only targets the netosis without increasing significantly bleeding risks. That would be a solution, yes.
Okay. But for now, yeah, the patient tonight, what kind of dose would you give to this patient?
Depends on the bolus, the dose of the bolus. If the dose of the bolus is high, then I would compensate it with the heparin flush. I would not give both high, and also depends on IVT and depends on the patient you're dealing with. But if you look at the literature, it's around 2,000 to 5,000 units per liter. 5,000 is a bit high, but I think around 2,000 units per liter, yes.
Okay.
So as for now, there is no consensus, there is no randomized data. So you have to do it with available variables and information you have at that point.
or design an appropriate RCT
Or design
to
an
sort this out.
appropriate RCT.
Okay, I hope you will contribute to that process, and thank you for your questions and answers. Thank you.
Thank you. The opposition will be continued by Dr. Truiman, vascular neurologist at the MUMC+.
Dear candidate, of course, first of all, I'd like to congratulate you with this excellent thesis. Of course, congratulations to your team. I enjoyed reading it a lot. It's impressive to see how extensively you studied many different aspects of acute stroke treatment. Well, as a neurologist with a special interest in vascular neurology, I always curious to see how we can expand the eligibility for patients, the treatment of patients, and many chapters of your thesis are relevant. I would also like to discuss a bit of chapter 7 in particular, because in the last years, I think the selection criteria for endovascular thrombectomy has been broadened, time window has expanded, imaging criteria has changed, large core infarcts are treated, and I think it's all in line with Proposition 3. I think given the time, we don't ask anyone to read it out loud, but I think given the scarcity of resources already discussed, we do need to stay a bit critical on who to treat and who we can treat best. And then in Chapter 7, you state that despite the American guidelines stating only including MRES 0 and 1, it makes sense to treat also MRES of 3. I wasn't aware of this, to be honest, I wasn't aware of this American guideline recommendation, and I didn't know, couldn't find any European guidelines on this. But now I know your study and the guidelines. Should I change my daily clinical practice, waiting for an RCT to perform EVT on MRES 3 patients, or you forget the American guidelines and still perform EVT on these patients?
Highly esteemed opponent, thank you for your kind words and your question. Again, I think currently, without randomized data, you have to treat each patient with his own information and important variables. Okay, pre-stroke disabilities are one aspect. The main conclusion we try to draw with this paper is to not routinely exclude those patients, but to stay critical, as you said, and continue thinking, and because, like we also showed, is that the reason why they got a pre-stroke disability varied immensely, and as in the conclusion stated, that patients return to MRES 0, 1, and 2. So the conclusion of the thesis was not to treat those patients or don't treat those patients, was more to be critical and to really think of, okay, is this a true reason why I should not treat these patients? And also, if you would translate it to, for example, patients who have brain atrophy, and there are papers that if you don't treat those patients, they do much worse. So the effect size, if you're really disabled or you have some atrophy, the effect size only grows when you get higher in this burden. So to come back to your question, I think you should still be able to treat or not to treat. I think there is no really hard cutoff for that.
Okay, so despite the American guidelines, still try to treat them if appropriate.
If appropriate, yes.
And I was wondering, in your study, the patients included were a patient with a relatively high NIHSS, average on 15 or 16. Would you expect the results to be differently if there would be a lower NIHSS?
That's a very good question. In this paper, we used the Mesokin registry data, and the other papers we used the ESCAPE NA1 data, and the NIHSS scores of both of these papers were high. So there was good patients with very bad strokes. So the benefit of treating was high. And in this sense, also here, a patient who is good and has a pre-stroke disability but has a very severe stroke, the benefit would be higher compared to patients with minor strokes. Then the risk of making complication would be much more relevant, I think.
It is a challenge between
It's a
lot to lose, lot to gain, kind of.
exactly.
Is there room for one more question? This registry was only within the first 6.5 hours of symptom onset. Do you think expanding the time window for this specific type of patient, would that make a difference? Up to 24 hours?
Well, if you again look at, if you would correlate the pre-stroke disabilities with the fact that they would have less brain reserve, and that's, I think, a doable hypothesis that patients who have more comorbidities will also have less brain reserve, then they would fall in would fall in the category of fast progressors, and waiting in these kind of patients would give them only less chance of being eligible for thrombectomy. So I think at first we would have much less patients with pre-stroke disabilities because they would not be eligible anymore.
Okay, thank you very much for all your answers. Giving the word back.
Short questions will always be followed by long answers. That's the problem. The opposition will be continued by Dr. Winkers, internist specialized in vascular medicine at MUMC+.
Sorry, I would also like to congratulate you and your promotion team with this thesis. For me, it has been a great pleasure reading it, and I also learned a lot from it. There were a lot of chapters out my comfort zone, but a few I'm into. And I would like to start with chapter 7. And then on page 147, there is a table 2. And the table, you compare the patients that are non-reperfused with the patients that are reperfused. At 30 days, there is a mortality rate of 92%, and then at 90 days, there is a mortality rate at 64%. I think that's quite confusing, so I was wondering if you could explain this to me.
Highly esteemed opponent, thank you for your kind words. Thank you for your question. So table 2, 90-day mortality in the non-perfused group, I think you're mentioning, is 64%.
The same happens in the perfused group, where there also the mortality rates goes down as the follow-up increases. I think I can help you. It's because you don't have all the data at 30 days, so you have some missing data.
Yes.
But I think maybe you can be quite sure that patients who are alive at 90 days, they must have been alive at 30 days, so maybe you could have changed it. But what also appears from this table is that you have more missing data from the ones that are reperfused than from the ones that are non-reperfused. And do you know why these patients are missing? Do you know why patients are lost to follow-up? And could it be that there is a selected loss to follow-up, or is it random?
One reason why it could be that patients who are reperfused have more missing data than patients who are not reperfused is that you have to check these DSAs, and you have to say, okay, more than 50% is a TK2B, and these DSAs has to be available and has to be available in different angles. So it could be the reason that this could be the reason that is a bit skewed, that in one group there were less data available than the other group. But the structural reason why it's in that particular group, cannot come up with that directly.
Okay. I have more questions on this one, but actually in the introduction I became a bit curious. When I have an older patient and I ask them to come into my office, I see how they get out of the chair, I see how they walk. They come in, I ask a lot of questions, and I see how they answer. How good is their memory? I might even challenge their memory. And then based upon that, I make a judgment whether or not I think this patient functions on age, below age, or above age. So I actually do exactly the same thing as you do based on imaging, only I do it based on my conversation and how the patient looks. And do you know, based on literature, whether we are in agreement as a radiologist and an internal medicine doctor, or whether we disagree? Do you have any idea? Do you know if there is literature about? And is it still needed to use the more expensive CT data, or can you just do a judgment?
That's a very good question, but we are in a totally different setting. You're in your consultation room, and we in the emergency department where every minute 2 million neurons die. So, I mean, even the CT scan, you have to make a very quick glimpse of how the patient is functioning quote unquote, what is the biological brain age of that patient. So I don't know if there are publications comparing these two, but I do know that's totally different world, and some is acute and the other is non-acute.
Okay. And does it also mean that the brain age on imaging differs at the acute setting versus the non-acute setting? Because that would be really striking.
This is something that we mitigated actually in the papers, because we did want to avoid a bias of the stroke itself by using, as I said before, measuring the CC-ICT ratio on the other side of the stroke. But if you would not do that, then I think, yes, there would be a difference, because there's a stroke patient who has, if a stroke occurs, the brain will swell, the brain will become darker. So if you would not take this into consideration, then of course, yes, you will have different outcome, different brain age, just based on the population you have.
And probably you will also have different judgment from us based on the stroke that there is. So that might be that we agree.
Yes.
And it could even be a nice new research to see whether we really agree imaging versus judgment in clinics.
Yes, certainly.
Faysal Benali, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Bismillah.
Faysal Benali, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account for your previous qualifications, the committee has decided to grant you the degree of doctor. Professor van Zam is authorized to confer. Professor van Zam is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All right, please.
I'm sorry, this is in Dutch. Belooft u dat u altijd volgens de beginselen van wetenschappelijke integriteit te werk zult gaan, eerlijk en zorgvuldig, transparant, onafhankelijk en verantwoordelijk?
Ja.
Krachtens de bevoegdheid ons door de wet toegekend, volgens het besluit van de commissie hier tegenwoordig, verklaar ik hier bij u, Faysal Benali, tot dokter te bevorderen en u alle rechten te verlenen die daaraan volgens wet en gewoonte verbonden zijn. Ter bewijze hiervan overhandig ik u nu de bul, door rector, secretaris en overige leden van de promotiecommissie ondertekend en met het grootzegel van de universiteit bevestigd. Yes, Faysal, here we are. I have a small note because I wanted to say a few things. Our adventure started already in 2017 when you started your radiology training in our department, October 2017, more than 8 years ago already. And I remember that in the beginning you were interested in interventional radiology as well, and especially in neurointervention. But later you changed your mind, and now you are a well-known diagnostic neuroradiologist. So who knows, you can still rethink your thoughts at that time and join us in the intervention group. Anyway, I think you're quite happy with the job you have now. And I remember also that in the beginning you came to us and you were interested in doing some research. Although I also remember you didn't feel really like a researcher, but you were interested in well, should I do it and can I do it? And we started with a small and simple thing. Do you still remember this registry about this aspiration catheter, the siphon track? We did a registry in our hospital, and you were the one who guided that, and you wrote the publication, and it was a very positive publication about the siphon track. But unfortunately, I never heard about it anymore after that. So despite your nice publication, it disappeared from the market. The next thing was, well, then came COVID, so that gave a little break in our chances to proceed with it, and even COVID brought a wall between Belgium and the Netherlands. We both live in Belgium, and Christine, you live in Belgium as well, I think. And well, at least we had a big problem because we couldn't cross the border so easily anymore. But also you saw an advantage, you took your chances with COVID because there was a question from the Dutch acute stroke audit, who can write something about the effect of COVID on the stroke treatment in the Netherlands? And you put up your hand and said, yeah, I would like to do that. So that was your second paper, the effect of COVID on stroke. Both are not in this thesis, so you did more than is published in this thesis. No, this thesis that started at, when we had the Mr. Clean Med trial, and we saw that heparin was not very beneficial, but we neglected completely the flush. And we saw that, and you said, okay, let's see if we can find out what is the current practice, what is the effect, and that is the first part, or not the first part in your thesis, but the first thing you started with. And that was quite successful, and I think we have to continue with that as well. And then came a request from Professor Goyal from Calgary. Do you know someone who wants to do 1-year fellowship in Calgary? And I was thinking about you, of course. You were eager to continue on this track, and you went for 1 year to Calgary. And I think you had a great time. I was happy that we could visit him one day or a few days, because we had a meeting, the Dutch Calgary think tank. And my wife and I, we went there, spent some time in the Rockies, and spent some time with you. You picked us up from the airport. We went on a hike together with the whole group, and you and your wife were there as well. So that was a very agreeable time. And I still look back at that time as a very nice time. And maybe you will go back to Canada one day again, and we will visit you again, I think. So that was then where you did most part of your thesis, and I think that was a very successful collaboration, as most of the Dutch physicians going to Calgary have a very successful time there, and you are one of them. So finally, yes, you finished your training for radiologist in a hospital, and in the same time you finished writing your papers. You went to Belgium, become a neuroradiologist there, and at that time, when you work hard in the hospital, you still had time to finish finally your thesis. And I'm quite proud you did it. It's not easy to do it when you have a full-time job to finish these kind of things, and you did it. So congratulations. I'm now the first one that can congratulate you with this achievement, and I think you can be proud of it.
Dear Dr. Benali, after these very kind words, positive words, I also can congratulate you, and I can also do that on behalf of the whole community of Maastricht University. I think you did an excellent job, and I wish you a lot of success in your future career, especially in Tongeren. And with that, I close this academic ceremony. Thank you.